Thank you, Chair Takano. I greatly appreciate it, and I appreciate this testimony and hearing. Dr. Matthews, I know that all of us were thrilled to learn that 399 fewer veterans died by suicide in 2019 compared to 2018. That was much needed progress after many years of stagnation. What specifically do you think led to that improvement, and how can it be replicated moving forward? And do you also have data and information on what conflict or war, times of service, and the age range for the majority of suicide or suicide attempts that occur?
Ma'am, if you don't mind, I'm going to defer to Dr. Miller. I don't want to speculate on causes. Do we have any information as to how those numbers decreased, Dr. Miller?
I think that, as we've mentioned, the 2019 data reflects unprecedented levels of progress. That said, again, as we've all said, within the context of the critical number is 0 versus 1, and 1 is too high. With that in mind, I think what we learned thus far from the data is 2019 represented the full start, if you will, of SP 2.0 and our public health approach, the implementation of a clinically based plan and a community-based plan. It also represented the initiation of what we call SP Now, which was designed to focus on 5 target areas where we believed if we made as a team across the VA significant, meaningful changes, we would lower the suicide rate by 7%. And that's exactly what we saw occur within that. So I think it's an affirmation of the public health approach that espouses the importance of data, following good data, and building strategy, policy, and interventions that are based on a public health approach, combining clinical and community emphasis. What do we know in terms of the numbers and risk? We know that the highest count for suicide in veterans occurs in the age group 55 and older. We know that the highest rate occurs in individuals age 18 to 34. In both age groups, white males are the predominant highest risk, and firearms are the most significantly employed lethal means. Therefore, that's where our firearm lethal means safety campaign comes in, that is addressing both age groups and demographics within the campaign.
All right, thank you, Dr. Miller. And the reason for my question was because the veterans that I encounter, and I'm a 24-year military veteran, the withdrawal from Afghanistan has been extraordinarily problematic for them and has led to increased mental health issues. So Dr. Matthews, on our second panel, the Wounded Warrior Project and Mr. Armadeus will testify about the availability of substance use treatment in conjunction with inpatient mental health treatment, and how it appears that the VA does not combine these treatments or have a comorbidity treatment plan. If that's the case, what can the VA do to provide greater access to these programs? And I have very limited time, so if you could be brief, I'd appreciate it.
Yeah, I'll have to defer to Dr. Miller again.
Okay, that's all right. Mr. Miller, thank